What's up, everybody? Welcome back to another installment in the Owens Recovery Science Podcast. This is Kyle Kimbrell, and just wanted to jump on here and tell you a bit about where we'll be headed over the next few weeks and different things we got going before we kick it over to the podcast for today. We are finally getting back out there. We've been able to run 3 open courses now, thankfully. Good grief, man. It's been a long time stuck at home, so it's been nice for a few of us to be able to get out of the house, interact with you all, and share some blood flow restriction exercise knowledge and rehabilitation knowledge. If you are interested in catching our courses or learning more from us, as always, you can go to our website, owensrecoveryscience.com. Under the Get Certified tab, you'll find all of our courses, whether they be domestically here in the United States or internationally. And then we also have spots just to learn more for our blog, place for our podcast on our website. So that can just be where you go to find everything that we're putting out there content-wise. You can catch us on social media as well, of course. We're on just all the typical different channels. But our course is coming up soon here. August 15th, we'll be in Golden, Colorado at our friends Next Level Sports Performance and Physical Therapy. Then on August 29th, we'll be in Austin, Texas, as well as London over in the UK. So both of those courses on August 29th if you're interested. Then September 12th, we'll be in 2 spots. We'll be in Long Island. We're going to split the country. We're going to go Long Island, New York, and San Diego, California. That's got to be the largest. Well, I don't know. I mean, over across the pond, that might be farther from Austin to London, but we're spreading it out across the U.S. about as much as you can without going up into Alaska. So a couple of different spots to catch us on September 12th. Then at the end of September, we're going to close it out with 3 different courses. We'll be at Andrews Children's Institute in Dallas, Texas on September 26th. That same date will also be in Minneapolis, Minnesota, and in Little Rock, Arkansas. So a lot of options for you on September 26th, right at the end of September if you're looking to find us. And then we'll have a bunch more courses coming up in October. October is going to be a really busy month for us, and I think just generally busy as we're closing out the year. But for now, let's turn it over to our buddy Jimmy McKay and then a special intro after that into today's podcast. So really hope you enjoy what we've got in store for you.
This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
We are happy to have with us today one of the more famous experts in the field of BFR. First came onto the scene in March 2017 with his banger, blood flow restriction training and clinical musculoskeletal rehabilitation, a systematic review and meta-analysis. And known for his most recent hit, the effective BFR resistance training on exercise-induced hypoalgesia. Some refer to him as a doctor of philosophy. Some may even refer to him as the Drake of BFR. We know him as Luke Hughes.
Jesus, man. Have you guys ever had such a diva on that brings their own intro? That is like, I'm only going to do this if y'all play this intro that my team put together first. I mean, it's just like, maybe it's a European thing. I'm not sure, but wow, man, Luke Hughes, the Drake of BFR.
Did you guys did y'all get the signed copies of his articles that he mailed out
of the review?
Yeah,
I know that
I got one in the mail. Did you not?
You did? Oh,
yeah. Okay.
Yeah.
I bought one, a counterfeit one. I couldn't afford the actual signed one, so I went through one of those back end hacking journal sites, to find it.
Johnny, you have the just Luke's work on your TV at home, right? Like that's the art instead of the instead of Van Gogh, it's just like Luke Hughes's.
My wife loves it. So if you didn't hear the intro, because people fast forward through the first parts of podcasts, you got to at least listen to that intro because Kyle had some good work. Kyle, do you want to explain what the whole background of that is?
For sure, yeah. Shout out to Brian Goonan from Twitter. I think his handle is @TuneIntoGoonan, but is right now is I don't know what you call those things, avatars or whatever. But then whatever your name is, it'll say hops and squats. So clearly a man after our own heart who likes to squat and drink beer. But he did a little talk for like a grand rounds talk for HSS. He's up at Hospital of Special Surgery in New York. He and a colleague did a talk for Grand Rounds there at HSS, and he did the intro, and so he did like a little history of BFR, and he made some hip hop references for Dr. Sato and Jeremy Lineker. Johnny was Jay-Z, I believe. Is that right?
Word, baby. I got the best one.
Hova. and then Luke was Drake, and Luke has had a little maybe too much early success in his career. We had to bring him down a notch or two. So
I think mine. I didn't see it, but it said mine was I'm like Jay-Z because I spread the BFR or something.
I think that's what it was. Like
and Drake Luke is Drake because now he's everywhere. So like Drake. So that's who we got on today, man. Luke Hughes. He's everywhere in the BFR world right now. I can't keep up with him. Knew him when he was a young gun, and now he's gunning for all of us. Luke, what's your favorite Drake song, man?
Hey guys, thanks for having me on. And thanks for putting that intro together. Drake, I actually couldn't name a single Drake song.
Oh, come on, man. Well,
I appreciate that from those guys, but saying I'm everywhere makes me sound like COVID. That's not a good look.
Yeah. No, yeah, that's true. Well, if y'all want to check out the best look we have on our social media handles, we got we put out with Luke Hughes a picture of him to ask him any questions. So that was a nice shot that Kyle was able to round up as well, man. So no, all joking aside, man, Luke, we've known each other for a long time, and then you want to give a little background of kind of how you got started into academia and all that sort of stuff. And we'll put out there, you're over in London, in the United Kingdom, which is as COVID hot as we are in the USA right now.
Yeah. Well, first of all, before I do that, we're going to have to retract the part about the signed BFR papers. I didn't send one to Zach, so he's going to feel pretty left out when we.
Oh man. Yeah. And he's a sniper. You better watch out.
Exactly. I have to run. So thanks for having me on. I basically based over here in the UK. Was up in the East Midlands for my undergraduate and postgraduate studies, doing sports science and exercise physiology, and then took an interest in BFR just from reading around it, and then searched for PhDs, and there was one going with Stephen Patterson down in London, so I moved down here to do my PhD, and the whole general idea at the beginning of the PhD was using BFR as a clinical tool. So that was kind of the title. It was kind of a broad topic. So we had to come up with an idea for a clinical study as part of the interview and present it. And the actual study was an ACL one, which we ended up following up with. So the PhD was based at St. Mary's University here in London, in collaboration with University College London Hospital, which is one of the NHS hospitals, one of the biggest in the UK. So the idea was that we would get an honorary researcher position for myself there, which would enable me to do BFR research with the patients there. We had two options, kind of ACL or ankle fractures. We decided to go with the ACL. Just for me, it was a more interesting musculoskeletal injury and disease than knee OA. And also we had the ankle fracture patients. We envisaged a lot of limitations with doing that. With the ACL, we could kind of recruit them pre-surgery and do all the things we wanted to do. So we kind of we started by basically looking at the BFR methodology. So what was kind of the most appropriate way to apply it from like a safety perspective, but also an effectiveness. Primarily because in a PhD, it's good to show progression and logical thinking, how you've built your methodology. But also for me, I wanted to be confident that we were using a BFR tool that was the most safe and effective, because it was the first kind of its study in the NHS. So we wanted to kind of make sure we really nailed down the safety of it. So initially in the PhD, we began by looking at different types of BFR devices and actually what was happening with pressure between the cuff and the limb during BFR exercise, and how that impacted on things like the perceptual response, the hemodynamic response. So we set out doing that, and once we determined the best kind of device to use, we started then looking at how we prescribe BFR most effectively. So I'm sure everyone who's listening is aware from your guys' previous podcast and work that measuring limb occlusion pressure is the best way to prescribe BFR pressure. So we did a study where we looked at the effect of body position on LOP. So just comparing LOP in a supine, an upright, and a standing position. And that came about from the previous study where we were measuring LOP with individual supine, and we were doing it with a handheld Doppler, and I thought I'd hit LOP and we'd lost the signal. And then the guy was being really nosy and kind of sat up to look at what I was doing. And there was this rush of blood flow through again. So we were like, oh, hang on. That's kind of, not the most science, that's the rationale of the study, but we tried to make it sound a little bit more scientific when we wrote that paper. And then after that, we kind of dove in with the ACL stuff. So we did a pilot test with one patient, kind of with no issues, and we kind of refined the protocol, and then we went straight in. So we began by looking at the acute responses. So after surgery, 3 weeks after surgery, when we did a first acute session of BFR or heavy load, kind of what was the acute response? So in terms of pain, RPE, swelling, all these different things, just to see, is it going to be feasible to do? And then we followed that up with a training study. So it was an 8-week training study, and it was a criteria-based progression. So we recruited the patients, did all our measures pre-surgery. They had their surgery, and then 2 weeks after surgery, we started assessing them for certain criteria that allowed us to start loading them. Once they hit that, we repeated the testing and trained them for 8 weeks. So that was a really cool study because it was I think like the third ever BFR ACL trial, and then first in the NHS. So it was really good, and we were comparing directly to heavy loading. So we kind of skimmed over the low intensity exercise versus low intensity with BFR because we know it works. So we were like, how does it compare to heavy loading? And at the time at UCL, their protocol was to use heavy loading. So they started loading them heavy straight away. So, and it was like 70% 1RM heavy as well. So a good load. So we just compared it directly against that and included a lot of strength measures, a load of morphology measures, and a lot of function, pain and swelling stuff. So there was that aspect of it. And then we also had a feasibility aspect of it, which we figured was important for, informing future studies. So looking at things like the perceptual responses all the way through the training and looking at, how feasible was it? And that kind of, one of the kind of side findings from that was the pain related stuff, which we've now followed up with more recent studies and kind of tried to dig into that and find out, some mechanisms behind them.
Yeah, I think right now, if we're to look at kind of like where is Luke Hughes in this BFR universe, it's definitely kind of setting a standard with ACL and now the pain guy. Because even though that was the third ACL study, that was the first good BFR ACL study. That we can actually look at it from a standardized approach. Like you said, it also set up for a lot of other studies from what we understand from perceptual responses, the hemodynamic responses, and then all the way down to the end of like, now we got all these objective measures. So I think that one set the tone early on of like, this is good ACL work. Actually, we just got funded for a new one in the DoD, and I'm already using some of your design from that. The criterion approach is so much better to start off with, rather than everyone starts at 2 weeks, because not everyone's the same at 2 weeks. So everyone I've been talking, when like, how are you going to start? How do you know the rate to start? It's like, well, let's start with a criteria-based approach for these rehab type studies. You really have to, because objectively, when they're all the same is when you need to start, not from a time point. So good on you, man.
A good way to do that. I think for me, that with a PhD, I'm not a clinician by trade from undergraduate and postgraduate stuff. So there was a lot for me to learn from the physios and the surgeons at the hospital. And one of my supervisors was a MSK physiotherapist there, and like doing that criteria-driven approach was great because there was quite a big disparity in some individuals. I think it worked out that there was like on average 1 day difference between the groups for when they could start the intervention. They were all capable of doing a session by the time we put them on there. So it was definitely a better approach. I think looking back on it, it probably influenced the low dropout rates and the high adherence rates to our protocol after.
And an easy study design, that's another thing. So many of these studies are like, okay, after 1 week, we switch to 5 different exercises. And then week 3, we switch to 5 different exercises. Can you talk about your study design of if someone was like, well, I want to mimic Dr. Hughes' study, how would I do that in the clinical setting?
Yeah, so I think one of the key factors that kind of shaped the planning of the study and the design was the fact that it was the first kind in the NHS. So NHS ethics they're notoriously thorough, and there was only so many things we could change with it being the first study within that. So we used an RCT and randomized it, and I really wanted to blind it because those kind of trials are so much more robust if I'm doing all the measures using what group. So we managed to convince UCL to let us have some master students to come on board and run the training sessions. And they're on the sport and exercise medicine master's degree, so they were all trained clinicians. So that was really helpful to have for me, knowing that there's clinicians with the patients train them, but then also the fact that I could be blinded. Good for the measures. In terms of the design itself, so I spent a bit of time initially just assessing the kind of learning about the normal ACL rehab protocol at UCL. And one thing I learned quickly is that there's such disparity in ACL rehab protocols around the world. So I was trying to figure out, okay, hang on, how do I fit and modify this? So just started going to the rehab stuff. And at the time, what they were doing is starting at 2 weeks post-surgery, they would do some assessments, and then they would eventually, about 5 or 6 weeks later, start getting patients into rehab classes where they'd have 6 or 7 patients, and then they'd all do like a circuit of rehab. And they typically were just doing one strength exercise. So, which obviously isn't quite a lot, and I wish we could have done more. So we just went with a single exercise initially, and kind of that kind of shaped the whole of the intervention. Really, we knew we could only do one exercise, and realistically, we could only really get our patients in twice a week. I'd have loved to have had them in 3-4 times a week, but unfortunately, we couldn't do that.
Turns out, pretty much every clinical study right now is twice a week. That's the standard.
Yeah, and to be honest, I was quite happy with that, and happy to justify that in the thesis, because you look at Brendan Scott's review, and 2 to 3 sessions a week is effective for improving muscle strength and mass, and they were our main outcome measures. So yeah, it was. And I think the key thing with those studies is like just the pilot. We put one patient through it initially, and there were so many things we changed. The methodology, what it was for the paper, because we changed so much based on just the feasibility of what we wanted to do. Yeah.
And what's good about this, which we don't get a lot of our clinical studies, like over here in the States, we're not told you need to do 70% 1RM from the get-go with an ACL. And so your comparison being in BFR at a low load compared to a 70% 1RM was pretty cool to see how that all teased out.
Yeah, I think usually what they were doing there is just they were kind of getting patients in and just loading them as heavy as possible. They weren't doing like an official 1RM measurement, if you like, because their rationale was that it's so soon post-surgery. They were worried about putting them on the leg press and doing that kind of training. And also, to do that kind of testing, the physios didn't have time. They had 6 or 7 patients that don't have time to do that. So what we did was we took them out for testing and just proposed doing a 10RM and kind of working backwards from that. Is it more feasible? Patients were more comfortable doing it. And we just essentially, the rehab programs they followed stayed the same. So any of like the proprioceptive stuff, flexibility stuff they did that as part of the class. But we just took them out for the strength work. So we just took them out for 10 minutes and then put them back in. So kind of that was really the only element we changed.
Can you explain how you do a 10 RM? Because we get interested all the time. Like, hey, how do I figure out what this person's 30% rep max is post-surgical? So when you guys were measuring that, what was your methodology?
So when we did the 10 RM, so we were doing unilateral leg press. So we were training both limbs, but individually. So we measured it for both limbs to prescribe load relative to that. So we basically started like predicting what their 70% 1RM would be typically. And then we started them off in what we thought would be 5 attempts away from that with like 5 kg increments. So we just get them on the leg press, do a bit of a standard warm up, and then do an attempt. And our criteria was that they could lift the weight through full range, from 0 to 90 degree range of motion, and control the movement. And then we just kept going up in increments until we hit the 10 RM. So when we picked the 10 RM, it was for a feasibility perspective and for it to be a bit safer and for the patients to feel more comfortable. A 10 RM typically equates to around about 70% of 1 RM. So that was pretty handy for setting the load with a heavy load training group. But we essentially used some equations that were old school sports science papers. I think it was so I think I was 7 when this study was put out. And essentially what you can do is plug in the weight they've lifted, the amount of reps they've done, and a few of the things into an equation, and it will give you their predicted 1 RM, and we kind of work backwards from that. So that's kind of how we did that. I think the 5 RM approach, you guys did that in the knee arthroscopy paper, the 5 RM as well.
Yeah, that's what we did. But 10 RM gives you a lot more wiggle room. There was just some validity issues that some of our folks were concerned with And the docs were a little nervous too. So we did a 5RM. So,
Yeah.
yeah, so you blew up and became Mr. ACL after this, right? So you've got a book chapter that I was part of with you on ACL rehab. You've got, what, 3 papers out of this study that have been published?
Yeah, Hughes study and train study and a feasibility. Yeah, feasibility paper out of it.
Yeah. And then I tried to figure out how we first met. And so I already knew Stephen prior to meeting you. So I pulled up old emails. And so we first started talking in 2016.
Wow.
And so, yeah, it's crazy, right? Time flies. And so you were reaching out to me about a feasibility study on trying to figure out what's the best kind of cuff to use and how can you validate it. And that's when you explained kind of what your study design idea was for ACL. I was like, oh, I like this, man. This is nice. So then I came back to you and asked if you would write the ACL section of our techniques in orthopedics special section. So another freaking ACL one. So then you took off as Mr. ACL guy after that. So it's been a while. So let's wrap up this study from what you found. We've talked about it a lot on the podcast, but at the end, kind of heavy hitters, the differences of lifting heavy or lifting light with BFR from your NHS study. What was the outcomes?
Yeah, so a number of interesting outcomes actually. So we'll try and go through it in a logical order. So our main outcome measures were muscle strength and muscle size. So we had a 10RM as our strength measurement for our isotonic measurement, and essentially we found that both groups significantly improved over the 8 weeks with no difference. And was kind of hoping for that and expecting that, because based on some of the literature that was published before that, studies were starting to show, especially those individualized in pressure, were starting to show comparable adaptations in clinical or injured populations. So we had comparable improvements in strength, isotonic strength. When we looked at our muscle morphology methods, so we had muscle thickness and pronation angle of the vastus lateralis. So that was the muscle we picked, and we picked it because it's one of the muscles that atrophies the most in the knee extensors. But also it was really easy to measure via ultrasound, so it was quicker for me to do that. So essentially, we found muscle thickness and pronation angle increased, so that as a marker of hypertrophy, and again that was similar between the groups, which is kind of what we hypothesized and expected. The interesting thing was then we looked at our physical function outcomes. So we had 5 different self-report questionnaires for our subjective measures, and we also included some objective measures. Now, there wasn't a great deal of studies before that had included objective measures of function. And while I think the subjective stuff obviously is really, really important, I kind of like to see it alongside an objective measure, just because I think it's a more of a true reflection of what's actually a change and what's happened. So we had our 5 different self-report questionnaires, and all of the BFR group reported better improvements in function in all 5 of the questionnaires. So, and bear in mind, at the point where I'm analyzing this, I just know them as group 0 and group 1. So at this point, I'm thinking, please God, let this be.
We've all been there, man.
This will be an amazing finding. So that was good. And then for our objective measure, we had the Y balance test. So we were looking at reach distance in the anterior direction, posterolateral and posteromedial. And again, we found that the BFR individuals improved greater reach distance in all 3 of those directions. So, they were saying they felt like their function improved better. They were self-reporting that, but actually when we objectively looked at it, it was better. So that was brilliant. And I thought this is amazing. And kind of then I was thinking, well, why has that happened? Because if strength's gone up the same and muscle mass has increased, so size has increased, why is function better? I think probably the most interesting part for me was when we looked at the pain and the swelling data. So we measured pain using the Hughes subscale, and then we measured swelling as mid-patellar joint circumference with a tape measure, and essentially we found that there's a greater decrease in pain. So it was 67% in the BFR group reduction versus 39% in the heavy load group, and then there was a 6% reduction in swelling with BFR group as opposed to a 2% reduction in heavy load. And then when we measured range of motion, the improvement was greater in the BFR group again. So, we figured that less pain, less swelling contributed to greater range of motion in that knee joint, which probably resulted in greater performance in the reach test, especially when the injured limb is the stance then. which then translated into them self-reporting better function. So those were kind of the outcomes from that. So that all tied in really, really nicely, and I think it really captures, how all the effects of BFR, not just muscle mass and strength, which was kind of the old focus of BFR, showing that we can actually really have beneficial improvements in function.
Yeah, that's kind of what we've always said. If you're using this in the early acute stages where you probably should not be putting too much load that might piss the knee off, this is where BFR is it's in its wheelhouse. And then once you're done after that 8-week intervention or so, that's when it's time to move on. And now it's started getting into the heavy load phase and kind of transition into kind of more higher end active type of things, but you don't have a pissed off knee. So they're already feeling more confident. It sounds like from self-reported, they're functionally, objectively showing you that. And strength and hypertrophy was really equal between groups. So it's beautiful, man. Everything you wanted, you got out of it.
Yeah, no, it was good. It was good. And, looking back on it, I suppose it's easy to do this. And a lot of this, there was a lot of focus on this in my PhD Viva with the external examiner, because he's an ACL expert. So he was kind of talking about like kinesiophobia and all these other measures that I kind of didn't do. And, using TMS to measure atherogenic inhibition, all these other things. So I think there's still so many unanswered questions. And in hindsight, really, for me, like starting at 3 weeks post, which I think that's what it was, approximately about 21 days post, I think that's too late really to start using BFR. There's, know there's the cell swelling, there's the BFR and electrostimulation, so there's BFR and aerobic exercise. So I think hopefully it paves the way for people to go, actually, yeah, we can start early, and there was no safety issues with this. So, the positive findings we got would be even better and maximized with earlier interventions.
Yeah, it definitely made for a great paper to share with folks. If they're asking for a good resource for clinical application post ACL, I mean, having something standardized, Objectify 1RM, people are typically in a busy clinic space and they're like, all right, well, I don't know that I can do the whole treatment session and get, 3 to 5 exercises with BFR. So how do I really utilize this clinically? And it's like, well, it looks like if you can do one multi-joint exercise twice a week for 8 weeks, that's pretty darn effective, if the load is prescribed well. And also, if you meet all the reps for a couple sessions, you bump the load by 10%. After 4 weeks, you retested 1 rep max or 10 rep max, and then progress the load from there. So gave some really good basis for how do we utilize this in a clinic space.
And it's getting better now where people aren't having to justify BFR, although I still probably get an email every other day from someone, like, will you talk to my surgeon or whatever? And so I think what's beautiful on this paper is it's nice to have NHS worked into the title. So yeah. It's a RCT blinded done through a uni with NHS, and Dr. Haddad is on it. Who's really thought of, he's kind of one of those orthopedic guru gods over there in Europe that a lot of the US doctors know. And I know a lot of doctors around the world know. So those are nice kind of like, this is a study to share with your doctors.
Yeah, I think we had 4 surgeons. So Haddad is one of them. And then we had 3 of the other surgeons working underneath him who were on board for the study. Kind of when we initially started, and he was kind of part of the supervisory team, and he was like my line manager for my research position there. Just went with him and pitched the idea and worked with it, and then it was like, okay, approach the surgeons and ask them, and they were really, actually, I was surprised they were really keen to do it. They just said, show us some safety stuff from previous work, any other ACL stuff, and they were like, what's your risk assessment, what's your safety measures? And they're like, yeah, okay, go for it, and just let us know. And now, I've left there now, but I have a couple of friends who are clinicians around London and who helped out with the study as MSc students at the time, and we became friends. And the surgeons there still refer patients on for BFR to these other individuals. So, and they've been doing another study in the ankle fracture. So the ethics we had during the PhD, we didn't pick up that study in the end, but that's kind of been ongoing. So, I think there, by the time we was finishing the PhD, a lot of the physios were approaching and saying, can you come and have a chat? We want to integrate this in kind of our practice and standard of practice to offer it to everyone. So I really think that was kind of the most positive finding, really, that the fact that people really kind of believed in it, because as you said, there's a lot of apprehension, especially in hospitals sometimes, about it.
Yeah. Well, especially in Europe, you're not seeing it nearly as much as we are in the U.S. So this is like a real trailblazer.
I was real curious about that too, Luke. If it did kind of change practice patterns to a degree, just based on how well it went. So that's cool to hear. That it seems to, at least in a small subgroup of people, have changed that. Something Ben kind of just brushed on. One of the things we discussed here before about your study that I thought was interesting, and also I think informative for people that listen to our podcast is you had a criteria to progress the load during, but then there was also that point at 4 weeks into the session where you remeasured 10 RM. You actually physically had them do the test and you prescribed load based on that finding, and in both the heavy load and the light load BFR group, that load went up somewhat substantially. Even though people had been being progressed by a certain criteria, and you saw it in their perception of the intervention that day and that sort of thing. So I thought that again, there's a lot of people more and more I hear in our field really pushing, like you have to test. You've got to test this movement. You've got to put this person under some load and have them do it. And you guys really kind of showed it, I felt like, in that study. So that was cool to see. Was that something that surprised you all, or was that kind of expected? What did you think?
So the rationale for that came from the systematic review and meta-analysis, because that was the first thing we did when we set out, because that's the best way to kind of say, right, all the BFR clinical studies that are here so far, yes, we want to look at the effect size for what's happening to muscle strength with our comparison. So BFR versus low load, does it improve strength more? BFR versus heavy load, does it, what's the difference? But then also that the systematic review part, so looking at studies, what measures they use, how do they prescribe pressure? And one of the key factors in the tool we used to assess the quality was, do they prescribe load? And I was actually really surprised how many of the studies hadn't progressed load. And some of them were like 8 weeks, some of them were 12 weeks, and they hadn't progressed load. And I'm thinking, if you're training 3 times a week, you're getting stronger. So we wanted to make sure we did that. And we figured, okay, 8-week training intervention, like a formal, if you like, retesting of load at 4 weeks. But even then I thought twice a week, they're going to get stronger. So we kind of came up with an idea of how to progress it. And we went with, if they completed all repetitions, so the 75 rep protocol, common with BFR, so the 30, 15, 15, 15, we said if they hit all those reps on 2 subsequent sessions, we put the load up by 10%. And when we discussed this in my PhD team, kind of one of the issues that was brought up for one of the supervisors was, they may end up doing completely different volumes of work. So kind of, this could be something that could crop up in publication review or in your Viva. And I was like, okay, well, we can just deal with that when we get to that, because for me, it's clinically relevant anyway. And it turns out that actually, I think there wasn't a massive amount of difference in the actual amount of load increased relative to what their strength was at the time. But that was really good. And when we look at like the amount of reps done per session, whenever we up the weight, the reps went down, and then they were hitting failure earlier, and then it crept back up, and then it came down again. And as you said, it's reflected in kind of the RPE. And when we did the formal reassessment, I remember I looked at that data for RPE, and it was like kind of, it stayed quite consistent throughout. And then there was a huge jump after week 8. And I thought, where has that come from? And I went back through all the paper and thought I wrote it down wrong, and then realized it was because the load had gone up from the retesting. So I think key thing being the feasibility, like we showed you can do it. You don't have to do formal retesting every week to progress the load and the patient.
And people, I mean, post-op after an ACL, that number, it can be changing really fast in a clinic type setting, because the knee's settling down, hopefully. People are feeling better and more confident. That really can change the amount of load someone can allow to cross that joint. So, having that criteria in a clinical study, I think, is just extremely important, and really smart of you also. Yeah. I guess I'm saying kudos, Drake. That's all I'm saying.
Way to go, Drake.
Way to go, Drake.
The key thing too is it's time. It's always like when we're setting up studies, it's like clinical burden. Clinical burden. You're putting too much clinical burden. But if you're reassessing it at the halfway point, it works, and that's not a clinical burden by any means. You can have 1 day out of that 4 weeks where you're retesting RMs, which is beautiful. Because I think we all think, well, we're just increasing load each time, so obviously we're on track here. But we always undershoot in rehab. We're learning big time.
Yeah, I think it was just kind of having the looking back on it, one of the things I kind of would do in future studies, if we do the same thing again, would be to the post-op testing, to repeat it maybe 2 days later before we prescribe load, because I always wonder how many of those patients might have pushed more 2 days later because of, like, I don't know, like a bit of a kinesiophobia thing. Were they afraid getting on it for the first time post-surgery? Again, this is something that came up in my Viva. Should studies potentially be assessed 2 days later? Is that more of a true reflection of strength? Potentially. The counter argument from our study was that we tested them pre-surgery, so like they were familiar with the protocol. They've been on the leg press, so we hopefully minimize any chance of that happening. But obviously, these are all things in an ideal world, and as you said, there's lots of restraints clinically, but load shouldn't be one of them.
And so, getting a little bit more into the specifics, then you used 80% LOP.
80% LOP, yeah.
Everyone started at 80%, or you built up, or?
So we went straight in with 80% LOP, yeah. So and then I think what we found was that looking back on the data after the unblinding, was that a lot of the earlier sessions in the BFR group, they weren't doing many reps at all. Like, everyone got the first 30. Then maybe half the individuals got the second 15, and then nothing in the third set. I think a lot of individuals did the 30, and then they did 2 after that, and then they couldn't do any more. And it might have been more to do with pressure. In hindsight, probably best clinical practice probably would be to maybe reduce it down a little bit and get more volume. From the purpose, with my PhD hat on, I was thinking, well, we don't want to fluctuate the pressure too much, because then there could be a lot of differences in the stimulus everyone's receiving. And actually, what we found was that by the third session, everyone was fine with it. So I'm a firm believer in just getting people through it and getting them familiar to it.
So I think that's key. We just had a big call for the femur fracture trial, and that we start at 80, and we'll allow it if they can't get into like set 2 or complete set 2, they can go down to 70. If they're still having trouble, they can go to 60, and then it stops. Then we deflate. But the key point too is, almost after 1 or 2 sessions, that's never an issue again. It's just and it's that thing. We can't predict when someone's gonna have a femur fracture, but it's almost like, I wish we could have attenuated these people to this prior to the study, a prehab, have them do it a day or 2 pre-surgical, just to understand, this is what it's going to be, and we might not run into that. But again, most people who might be nervous, they can't handle it, because we just onboarded 2 new sites, and that was the biggest question. What if, I don't know if they can handle that pressure, because they've already been doing BFR there, and it's like, they'll be fine. Just get them through the first 2 sessions. It's okay. So with that, then going back from, like when we first met, one of the questions you had was, you were doing the validation study. Do you want to go into a little bit of like what you were looking at and what you're trying to validate, and how you came to your decision of what to do?
Yeah, sure. So that's just reminded me when you mentioned about how we met. I think it was Twitter. I think I reached out to you on Twitter.
Just like Kyle, he stalks me.
Same. Same.
Ben lives in my city, so Ben lives in the city, so he just wouldn't leave me alone. I'd open my door, he'd be standing in my driveway like, "Hey, Johnny."
I was just hanging out in Johnny's bushes, just waiting for him to come outside. I mean, you went the social media route. That's just really weird that you did that.
How did we meet on social? What do you remember, Luke? Just general.
I think I messaged you, direct messaged you. Obviously, like Jay-Z has a lot of followers, so I'm surprised I got through the net.
Yeah.
Said we had an idea for a study, and do you mind chatting via email? And then you popped the email, and that's when I said to you what our proposal was. But essentially, what we wanted to do was, it's more so now, but especially when I was starting out in 2016, there was already a few different BFR devices out there. And at St. Mary's University, Stephen, because he'd done blood flow restriction for his PhD, so we had a Hawkinson device, like the medical, the big huge cuff that goes from like the groin down to the
that's what we started with.
game ready compression thing. It just covers the limb. Well, we had one of those, and then we had some of the old style Delphi cuffs that Stephen had got from them a couple of years before. And then there was the occlusion cuff was out at the time. People were using handheld blood pressure cuffs. Wraps were being used. So I was kind of like, hang on, before we do this clinical study, surely we should have a look at compare the devices. And kind of the key thing was, this is kind of BFR is supposed to be doing X, Y, and Z. So like, what factors could influence that per device? So we kind of sat back, and I was having to think about, what could be the most important thing, and pressure being one of them. So we decided to look at pressure regulation. So one thing that kind of struck me was that people were setting pressures, and a lot of them were arbitrary at the time, and saying, okay, we're applying 220 millimeters of mercury in the cuff. And I'm like, well, how do we know that's what's happening in the limb? The cuffs might be 3 centimeters thick, it might be 1 centimeter thick. What's actually happening? So we decided to come up with a way to try and measure that. So we kind of developed this pressure sensor that is this kind of bit of a, not homemade, but we kind of put all these different systems together. Like we used some Pascal kit, and that's what I kind of approached you with and said, what do you think? And then you put me in touch with Jim and the others at Delphi, who obviously have a lot more experience with this kind of work, this biomedical engineering stuff, and they helped give me some advice on that. And essentially we just did an acute BFR session, and so we did a 75 rep protocol, unilateral leg press exercise, 30% more rep max, and we just put the sensors circumferentially around the limb underneath the cuff. So obviously the cuffs were all different widths. So the first thing we did was, when we put the cuff on as proximal as possible, we just marked the proximal and distal edges, took it off, measured the distance, work out the midpoint of the cuff, drew that around the limb, and then we basically divided it equally. So measured the circumference, divided it equally, so we had a sensor, anterior, posterior, medial, lateral, and put the sensors on, put the cuff back over in line with the markings, and then we cracked on with our measurements. So we did some rested measurements, which we can come back to in a moment, but the exercise stuff was really interesting. So we compared 3 different types of BFR devices. So we had the Hawkinson rapid inflation. So those guys are like filled with the compressed air from this big tank, and they inflate to full pressure in like half a second. So they're quite aggressive. So we had one of those. And then we had a like a handheld type pump, the ones that have like the pressure gauge and a handheld bulb, and you pump those up. And then we had an automatic unit, so the Delphi unit, which is designed to automatically regulate, so a surgical type tourniquet. So essentially what we did is we did a continuous pressure measurement throughout exercise, and we had the cuffs modified. So we had a separate line inserted into the cuff bladder within each cuff, so we could actually monitor the pressure we set at, so we know what we set them at, and we prescribed it as, say, 80% LLP. The B, we had the measure of what's happening inside in the cuff bladder, so what's the actual pressure in there. And then C, we had the measure between the cuff and the limb. So what that allowed us to do is record the pressure changes between the cuff and the limb and look at how that compared to what was in the cuff bladder. So we'd expect, if we set the pressure at, say, 150 millimeters of mercury at 8% LLP, we'd expect the cuff bladder to have 150 millimeters of mercury of air in it, and then we could see what was happening between the cuff and the limb. And interestingly, so when we were doing the study, I could see the visual traces, and I could see all these jumps around with certain different types of cuff. And I thought, oh, great, well, there's something happening there. That's pretty interesting. Essentially, what I did was averaged the fluctuations. So we had fluctuations above and below the set pressure, as we'd expect with different types of
as you're moving.
Yeah, so we kind of averaged that and then just compared. So we used like a bland Altman test and just compared the differences. And essentially what we found is that the kind of the manual handheld type cuff, so like your standard blood pressure cuffs you pump up, they were awful at regulating pressure, which is unsurprising really, because they're not designed to do that. So what we're finding is that when the cuff's on the limb and the person was concentrically contracting that muscle, it was getting shorter and fatter at the muscle belly, and it was pushing against the cuff. And because the cuff isn't designed to deflate and regulate pressure, there's a big increase in interface pressure. So for me, that's as good as the cuff applying more pressure than it should be, because that tissue is still experiencing more pressure. Right. I think on average, the difference was around 75 millimeters of mercury, if I remember correctly, on average across the exercise bout. So, say they were 150 millimeters of mercury at 80% LP, that's half. So that's a big difference in pressure. What we found alongside that, so again, to try and inform the feasibility, because we tried to make the perceptual responses and the feasibility of doing this in patients a big trend through the PhD. So we looked at the perceptual responses, and we found that in that cuff, individuals were reporting higher pain, higher RPE, and we actually found that the hemodynamic response was different. So that was that cuff. And then when we looked at the Hawkinson and the Delphi surgical tourniquet, these systems are designed to control pressure. And so what we found was that the pressure fluctuations were much more minimal. controlled, and then alongside that, patients, or the individuals, they weren't patients at this point, but the individuals reported less pain, lower RPE. So, you know, and it kind of makes sense, you know, less fluctuations of pressure, less pain, less discomfort. So that was kind of a really good starting point, because it was very, very obvious which type of BFR device we were going to use. And, you know, I would only use that kind of surgical type automatic regulating device in patients for that reason.
Right. Yeah, it goes along with the surgical literature, and some of that stuff's been done, but definitely your study took it to a whole different level. It was interesting to see, and you can just watch the sphygmomanometer on these little pump up things. It's like all over the place. So it's visually, you see that like, whoa, that thing went all the way to the end. I bet if it went to 800, it would have gone all the way around. And then, but then it's got that drift, so you can't even regulate and hold the pressure. That was our problem when we were first kind of messing around with it in the DoD. I mean, those things, after a while, it was just like, and that's what they're designed to do, is just to basically lose their air over time.
We included some resting measures, and it's kind of, whenever I've been asked about the paper, people always focus on the exercise component, and I get that, but we had some resting measures, and we measured basically just a 30-second inflation period with the sensors on, just passive, like passive BFR, I suppose, and we did it at 40% LLP and 80% LLP. And essentially we found that like the manual handheld type cuffs couldn't maintain the pressure. So we could see it visually on the trace. It was just the interface pressure was decreasing. And actually the cuff bladder pressure was also like decreasing as well. So it was kind of like this drift. So, you know, I think that has important implications for passive self-swelling protocols, because, you know, by the time you're on the third or fourth cycle, what actual pressure you're applying to that limb.
Yeah, or even during exercise, you know, it's going to be doing the same drift as well, as it does in the passive or static. So then I guess let's roll from there to when you start to get more interested in the whole pain, the analgesic effect, because really no one has put out a paper or study just addressing that with BFR. You know, Chris Bradner did some kind of perceptual stuff and things like that, but what was your thoughts on that, and what were you thinking when you started to want to go down that wormhole?
Yeah, so it kind of happened unexpectedly. So I think when we designed the ACL study, there were papers out at this time that had looked at kind of pain. So you had the Neil Way study by Fraz et al., a 2017 paper, looked at pain. We had the anterior knee pain with Giles et al. So they kind of started reporting with a training study reduced pain in the BFR group compared to either a low intensity group or a high intensity group. And in our ACL stuff, so our first kind of the acute study, we measured pain during the exercise and 24 hours after. And 24 hours after, we just kind of, I think we just kind of threw that measure in there, to be honest. I don't think there was a rationale for that. We kind of just went, let's see what's happening the day after.
How'd you do that? Did you call the subjects or?
Yeah, called them the day after. Yeah. So
okay.
Called them. Yeah. So I was cold calling these patients. They were probably slipping by the end of the study.
They're all block that number.
Hey, and like, you know, if I called them and they didn't answer, it was like, right, you're getting a WhatsApp text. I need you between 2 and 5 p.m. for this window that we've got. So,
yeah.
So when we measured pain, so we measured it during the exercise bout and 24 hours after, and essentially in that acute study, we found that pain in between each set was lower in the BFR group. And initially, we put that down to whether they're lifting lower load. They're lifting 30% 1RM versus 70. That kind of makes sense. You know, the knees are aggy and angry after the surgery, so that makes sense. And then 24 hours after, patients were reporting lower pain after having BFR training. So those patients in the BFR group reported less pain 24 hours after. I thought, okay, that's quite interesting. So then when we did the training study, as I said, we measured pain with the Hughes subscale, and we found that overall, there's 67% reduction compared to 39 with heavy load. So like, you know, almost double reduction with BFR. And then when we looked at our kind of feasibility type data, so we did the same measurements as the acute study throughout every training session. So we measured pain in between the sets, like 24 hours after every session. So that's detailed in our feasibility paper in Physical Therapy in Sport, where it's published. And essentially, they were reported, the BFR group reported less pain at 24 hours post the whole way through. I think it was by session 4, I think it was significantly lower than baseline, and it's remained lower for the remaining 12 sessions because they had 60 in total. So that's when we started thinking, hang on, there's something happening with the pain here. Maybe it isn't just to do with load. And around that time was when Vasily Karakis' paper came out, the two papers, Aspetar. So they had the pilot RCT and the follow-up. And that's, to date, those are my two favorite BFR papers, because I think it was a really nice, simple study. And they essentially took those patients or individuals with anterior knee pain and just got them to do low load training or the same protocol with BFR. And I think, if I remember correctly, they did 4 sets of open kinetic chain exercise, and stuff. 30% 1RM. I can't remember what pressure they used, but I'm pretty sure it was a high LLP pressure. And essentially they measured pain pre and post, so like a numerical pain rating scale, so nice and simple. And they found that the BFR group reported a greater reduction in pain immediately after. So it was within the first minute after completing exercise. And then the really interesting part was when they did the 45-minute physiotherapy session after, and then they reassessed pain in, I think it was the shallow and deep single leg squat and then the step down test. And they found that there was the patients who'd had the BFR acute intervention reported less pain in those movements 45 minutes later. So that's when I really thought, okay, well, they've shown acute hypoalgesia here, and not only immediately, but through a session, and they kind of reported anecdotally that the patients could tolerate more load in that physiotherapy session. And then that's when I thought, hang on, this has some really important potential implications for rehab. So that's when we kind of thought, okay, how is this happening, and what's driving it, and is it just for 45 minutes? Because we've seen less pain at 24 hours. So that's when I thought it could be a really big thing to look at there. So we then went away, and then I was learning about exercise-induced hypoalgesia. So, which obviously is a well-described phenomenon where exercise reduces pain acutely. And kind of from all the reading and things I was learning about it was that it's driven by the intensity and duration of the exercise. So the higher the intensity of the exercise and the longer the duration, for like resistance and aerobic type stuff, the greater the acute reduction in pain. So then I was thinking, okay, we're getting this reduction with BFR. It's low intensity and it's short duration. So like an acute session of 4 sets is what 5 to 6 minutes. So it's not long duration, and it's low intensity. So started reading around the different mechanisms that are driving or hypothesized to drive hypoalgesia with normal exercise, and kind of then figuring out how BFR, coming up with hypotheses about how BFR may be achieving that. So looking at those pathways. So we put that into a hypothesis paper, which was really cool to do, because when we started writing it, started really seeing the links, and it seemed quite obvious about how BFR could be having this effect. And then that's when we decided to follow that up with a robust kind of randomized controlled study.
Nice. And so do you want to kind of go in what the objectives or what you found in that study, and maybe even discuss some of your, if you want to, some of your future work of what you're looking at right now with that?
Yeah, sure. So essentially when we kind of were putting up together our hypothesis, there's several different mechanisms that are proposed to drive exercise-induced hypoalgesia. And kind of the consensus on that type of literature was that there's no one driving factor. There's multiple mechanisms at play that have a kind of synergistic effect. So we came up with our hypotheses, and then we decided to test a couple of them in the study. So what I really wanted to do was compare BFR exercise to the same exercise at a low intensity, well, without BFR. So kind of like the Karakis and the Aspetar guys did. So they compared the same protocols, and the only difference was BFR. Then I also wanted to compare to a heavy load session because of what we had in the PhD, where we found a greater reduction over training with BFR as opposed to heavy loading. And then also kind of decided, so should we kind of look if there's an effect of pressure specifically. So we'll pick a low end pressure and a high end pressure. So we went with 40% LOP and 80% LOP. So
in the lower extremity.
Yeah, in the lower extremity. So essentially the study was a lower limb loading protocol. So unilateral leg press, because apparently we love that over here in London. That's what we always do. I just realized that. I was like, damn, I need to do some upper body stuff.
Yeah. No, Jeremy does enough of that. We're good.
Yeah.
You can stick to lower extremity.
He's got it nailed. So we had a low intensity protocol, the same exercise with 40% LOP, same with 80% LOP, and then a high intensity group. And essentially we recruited just non-injured recreation active individuals who are pain free. We wanted to look at acute hypoalgesia. So essentially, it was a randomized crossover trial. So all the individuals took part in all conditions. And we started doing more and more of those studies. And I like those. I think they're the most robust kind of studies because, if you're seeing an effect of one intervention, and you can be confident it's because of the intervention, not because of a certain group of individuals or maybe a learned effect. So they all did it in a randomized crossover design. And essentially, the way we measured hypoalgesia was using algometry. So there's various different ways the literature's kind of looked at acute hypoalgesia with exercise, but we chose handheld algometry for several reasons. And essentially it involves using this little, it's kind of like tool. It looks like a Theragun, but not as cool. And essentially you put pressure on various trigger points throughout the body. So a lot of the Danish groups have done, they kind of the leaders in pain research. So we kind of took their protocol. So we wanted to measure hypoalgesia in the exercise and limb. But they'd also shown a lot of evidence of systemic hypoalgesia, so around other areas of the body that aren't exercising. So I wanted to include that because I figured, that could have important implications for rehab for someone who has an injured limb that can't be trained. Like thinking back your background, Johnny, with some of those blast patients' injuries, you potentially train another limb and get hypoalgesia effect in the injured limb. So we essentially got them to do exercise. So we just did the 75 rep protocol for the BFR group, and then the heavy load group did 4 sets of 10, and we essentially I modified the rest period for the heavy load intervention so that the interventions were the same time, because we controlled contraction speed so they ended at the same time, because that was really important for making sure we standardized the time where we measured hypoalgesia post exercise. And essentially all it involved is applying pressure on these trigger points in the body. So we did the quads in the exercise and limb. We did the non-dominant quads or the non-exercising quads. We did the dominant bicep in the upper body, and then we did the non-dominant trapezius. So that, again, we kind of just mimicked the protocol that was done in the pain literature to see how BFR kind of would compare. And you just put pressure on these trigger points with the algometer, and you get a reading in kilograms of force, which is what we used. And essentially, you apply the stimulus, and you just instruct the individual, say now when it goes from discomfort to pain, so the first onset of pain. And then you just measure that pre and post. And when I read this literature, I was quite skeptical, thinking, there's got to be a lot of variation in that.
Yeah.
There was some literature published on the reliability and stuff. So we did a lot of pilot testing, and I was amazed at how accurate it was from day to day in these individuals, and also how accurate it was and reliable at documenting the change, the magnitude of change. So then we did the study, and we wanted to look at some mechanisms. So we took blood samples, and we wanted to look at the endogenous opioid and endocannabinoid systems. So one of our hypotheses was that these endogenous pain modulation systems were involved in hypoalgesia with BFR. So these kind of systems are activated during exercise, typically specifically painful exercise or strenuous exercise. And we know BFR can cause quite a bit of discomfort in that muscle. So we wanted to start with that as our main hypothesis. So we took blood samples pre and post to look at that. And we did all our measures pre, post, and then 24 hours post. And essentially what we found is that in the exercise and limb, we saw pain thresholds, the amount of pressure that we applied before the person found it painful increased pre to post exercise, which is what we'd expect. So if we compare the low intensity and the high intensity group, the change was greater in the high intensity intervention or the session compared to the low intensity, which we'd expect based on what we know about exercise-induced hypoalgesia. And then in the BFR groups, so the 40% LLP and 80% LLP resulted in a greater change or a greater hypoalgesia effect compared to the low intensity exercise alone. So I was kind of like, okay, we know it's to do with the BFR now. And actually we saw a greater effect with 80% LLP, which kind of suggested to us potentially the pressure is an important variable for this. And that was in that limb that was exercising. So that was really cool. And the 80% LLP actually caused a greater reduction in pain threshold or pain sensitivity compared to the high intensity group. So that basically confirmed what we'd seen in the ACL study and what others have seen. High pressure, 80% LLP BFR was causing greater pain reduction. So we kind of
systemically as well, or I can't remember, just in a quad.
So that was in the exercise and limb. So 40% LLP produced a similar change as high intensity, and 80% was greater in the exercise and limb. All four of the protocols resulted in systemic hypoalgesia. So we saw a change in the non-exercise and limb, which the magnitude was smaller than the exercise and limb. And again, we saw a smaller change in the dominant biceps and the non-dominant trapezius, so upper body. Those other 3 remote sites that weren't exercising, there was no difference in pressure. So the level of pressure didn't affect the change, but 40% and 80% LLP produced similar hypogeusia as high intensity exercise, but obviously 30% of 1 rep max as opposed to 70. So,
and then endogenously, what did you see?
So in terms of our markers, so we'll just add to that, the interesting finding was the 24-hour post. That's still one we can't explain, because at 24 hours post, any change in pain sensitivity, which was our marker of hypogeusia. So in the low intensity protocol and the high intensity protocol, when the individuals did those, at 24 hours post, all those pain thresholds had gone back to baseline, which we'd expect, because with exercise-induced hypogeusia, typically it's 45 minutes to an hour you see the effect. When we assessed the individuals after they did both the BFR interventions, in that exercising limb, pain thresholds were still elevated, and it was only in that limb. So their non-exercising limb and their remote upper body areas had gone back to baseline, but the exercising limb was still higher. So that was really interesting. And again, at that time point, the 80% LLP seemed to have a greater effect. So that was really interesting, because it kind of, again, supported what we'd seen in the ACL study with the 24-hour post measures. But yeah, so in terms of the endogenous stuff, to kind of put a mechanism beneath those changes, so we looked at beta endorphin as a marker of the opioid system. And we looked at 2AG, which is a marker of the endocannabinoid system. And essentially, research has shown in animals and humans that when we exercise, these are released from cells around the body, and they bind to pre- and postsynaptic terminals in the peripheral, spinal, supraspinal pathways, and basically contribute to pain inhibition. So we measured beta endorphin and 2AG, and we hypothesized both would increase because they're increasing response to exercise, particularly exercise that's uncomfortable. In terms of 2AG, we saw absolutely no change whatsoever. So we binned that hypothesis because there was no changes from pre to post in any of the conditions. But the beta endorphin, yeah. So that was some boring analysis. But the beta endorphin was interesting. So again, we saw an increase in the high intensity group, slight increase, and then the BFR group there was a way bigger increase. I think it was like 27% change from baseline in the 40% LLP group, and like a 33 to 35 in the 80% LLP group. So we were seeing beta endorphin was increasing as a result of the exercise. So that was the endogenous findings.
And that marker was only measured at the acute post-exercise. You weren't able to catch that at 24 hours.
No, so that was we did measure it 24 hours. Sorry, so we did it at 10 minutes post, which showed us the increase, and then at 24 hours, those levels have gone back down to normal. So leaves that bit of a mystery for that 24-hour elevation. It's like, well, the beta endorphin's gone back down, so it can't be the only thing contributing to the hypogeusia, but obviously it seemed to have an effect because we did like a mediation analysis which allowed you to work out the magnitude of change in pain sensitivity and the magnitude of change in beta endorphin in each individual and work out how much it influences that. And I think it explained the change in beta endorphin endogenously explained about 54% of the relationship between the exercise protocol and the change in pain sensitivity. So again, it shows that beta endorphin has some role, but it's not the only thing that's contributing to this hypogeusia. And that kind of makes sense because from the normal literature, non-BFR stuff with hypogeusia, that's what it suggests as well.
You know, I just wondered though, is it hard to pick up beta endorphin or those endogenous opioids at the 24-hour time point? Are they already bound to receptors and you're not getting it from your draw?
Potentially, yeah, that's a good point. But I think if we look at the 24-hour measures, they were similar to baseline, so our pre-exercise kind of measures. So I think just at that point there was no simulation. It was more the resting endogenous levels they were back at. So yeah, I
just want beta endorphin to work because I've already made the slides for that one prior to your study. That was where I was going.
Yeah.
Don't even do 2AG because that.
Oh wait, yeah, I didn't even go there. Because when I speak at conferences, I can't say endocannabinoid. I can barely say it right now. So yeah,
that's why I call it 2AG. The actual name is glycerol, and then the first conference I presented that paper, I just looked at it and went, do you know what? No, we'll call it 2AG because I'm not going to.
You guys good with this?
I tried to hooked on phonics that word yesterday when I was reading your paper, and I'm like, I don't even know. I can't even get there. There's too many
It's
letters and
impossible
stuff.
to get out. I've tried to say it, speaking in conferences. It's
It
impossible.
is.
Well, what do you think then, man? Mechanism wise, 24 hours right now, your gut.
Part of me, the pessimist in me, part of me thinks potentially it might be the individual's own perception.
Mhm.
So what we've seen in individuals in our studies doing BFR, and when I followed up with the patients after, when I'd been unblinded in the ACL stuff, was that they said how great they felt after it. I'm wondering if maybe that there's a somatosensory change where they think, oh, I feel good, so their pain thresholds are different. But I think there potentially is some kind of change to like neural pathways. So the next step is to look into using TMS, so to measure what's happening. I think Jill Cook's some of the isometric stuff they've done, they've looked at like channel changes, and they've shown changes with isometric based stuff. So for me, I think that probably that's what I think would be the big driver at 24 hours.
And Luke, I'm not as familiar with the other, exercise-induced hypoalgesia research. What is a typical time frame that you see, hypoalgesia after exercise, if it's enough to create hypoalgesia?
So yeah, typically based on kind of like recent reviews of all the exercise hypoalgesia stuff, it's about anywhere between 45 and 60 minutes. So, which is great because obviously that allows you to do so much more with a patient. Or just gives them that relief when they're going home. But I think, with BFR, we're having an effect at 24 hours. And I think we showed it in the acute ACL study to an extent. We showed it in the training study, and then we've shown it in non-injured individuals who are pain-free. So that, it's not just having an effect on existing pain, it's their resting pain sensitivity we were changing. So I think the 24-hour thing has so many implications. Like the idea of the interesting thing for me with acute hypoalgesia is the potential for rehab in certain conditions. So like the tendinopathy thing always comes up when I mention hypoalgesia with BFR.
Yep.
So tendons require high load in order to adapt and rehab. So would BFR potentially work for tendons?
Maybe.
Yeah, but do they?
Whoa,
Maybe.
whoa, let's not go there. Let's not go there. This is a whole nother conversation.
But the idea is that if we can, and the Caracas work showed this really nicely, they can acutely reduce pain, and individuals could tolerate more load. So I think from a rehab perspective, if we could do a quick acute for the individuals you needed to load, for different conditions, and as a clinician, you guys will know more about that than me. But if you can acutely reduce pain with 5 or 6 minutes of 4 sets of BFI exercise, and that could improve subsequent rehab stuff, and the 24-hour stuff I think is great because you can't see patients every day, as we've discussed, unless they're in the bed rest that are trapped. But
in the Caracas guys, Aspetar, they even mentioned that paper. This should be looked at as a preconditioning exercise. So if you're going to program, and we've talked about it, put it first in your session. And so luckily that's kind of the way we were doing it before we went deep into pain, because it was more like, well, let's get them fatigued if you're going to work on proprioception and things like that. But I believe it. It happens. It's the reason why we're all going down this road. We've all seen it. And I've always said that post-op arthroscopy paper, that was our first goal, was just to see where we causing more pain. And their Hughes went down and had less pain as well. So not only clinically, this is a big thing with all the teams we work with. The playoffs, you got an NBA guy, he's got this nagging, patellar tendinopathy type thing, not bad enough that he can't play, but he wants to get some relief. So they're using this pre-game to get 45 to 60 minutes at least. But then we get this anecdotals like, hey, he still felt like he was getting some relief the next day or two. We get that so much. Their question is always a concern with fatigue. We want to time this to get the biggest bang for their buck, but we don't want to wear their leg out by doing BFR right before a game just for analgesic benefit. Could we do 1 set or 2 sets, keep the cuff on, maybe just hold, maybe is there something driving that from the hypoxic event? We've seen the few studies that have looked at pre-surgical doing ischemic preconditioning and getting this kind of reduced opioid use and reduced pain scores. So, could it be hypoxia, not exercise? Would be interesting to see as well.
Definitely. And we're halfway through replicating that same study, but with aerobic exercise. So pretty much the same design. So the randomized controlled crossover same pressures, but it's just basically an aerobic exercise protocol. So we're doing 20 minutes of low intensity aerobic silence, so 40% VO2 max. Basing it on one of Lonicki's papers where they looked at adaptations to low intensity aerobic exercise of BFR versus high intensity. I think it was a 6-week study. So we kind of took that protocol because it's been shown to be effective at improving muscle mass and strength. So we're like, what potentially can that protocol do for pain? So we're halfway through that, and it's obviously on hold at the moment for obvious reasons. But that's going to be really interesting as well, because if we can have the same kind of effect with aerobic exercise, it provides an additional option for patients you may not even be able to load yet with weight resistance.
Yeah.
So.
Yeah.
Okay,
Next would be stem. There's a million.
Yeah.
Let's see what it does with stem next, and then just see with just cell swelling.
Yeah.
Sorry, Kyle.
No, that's okay. Luke, I had a question, in part because we get this a lot, and then I thought it was kind of interesting reading through you and Stephen's hypothesis paper. One of the papers that you all reviewed looked like it was looking at exercise-induced hypoalgesia in like a chronic pain type situation. And it seemed as though in that situation that there may not be an effect. And so wondered if you could maybe expound on that a bit. And then ultimately kind of the question on our end, on the clinic side is, well, what about that person that has like a CRPS? We've gotten that question a lot. I know we've also kind of posed it to Johnny because they certainly saw a lot of that within the DoD. So is there potential to use this in a CRPS type scenario? Do we think maybe it doesn't work in chronic pain for some weird reason? What kind of thoughts do you have?
Do you know what CRPS is? Like, everyone has different terms for it now.
Yes, that was my first question.
Sorry. Yeah. So it used to be RSD, reflex sympathetic dystrophy. Now you have CRPS1, CRPS2. So complex regional pain syndrome 1 or 2. 1 generally involves direct injury to a nerve, and then 2 tends to be kind of like a different sort of etiology, if you will.
Can't even explain it half the time.
Yeah.
So it's essentially that's kind of the next step, I think. Looking at the exercise-induced hypoalgesia literature, a lot of the studies have shown exercise causes hyperalgesia in some individuals with chronic pain. So I think the next step is basically to replicate what we did, but do it in individuals with chronic pain and see.
Yeah. I also noted something from your paper here. I wanted to make sure I got this right. I'm just going to quote a sentence for you here, if I can get it right. Oh, where'd it go? Oh, here it is. So in that hypothesis paper, it said the following sections provide an overview of the, no, that's the wrong one. It serves as an agonist for opioid receptors throughout the central nervous system and peripheral nervous system, particularly of the mu subtype. So when I read that, I thought, oh, mu, now we're talking barbecue. And so I just needed a way to bring this back to,
how long
to
did
barbecue.
You work to have this?
Yeah.
No, I didn't work at all. I read that immediately. I'm like, oh, I got to ask Luke about that. It's a perfect way to work barbecue into the conversation tomorrow. I'd never heard of the mu receptor. And so anyway, I don't know if you want to expound on that. It's great. But I was mostly just trying to work barbecue into the conversation.
I don't even know what your question is now. What's
It
the
really
receptor? Is that what?
We'll wrap this one up quickly, but yeah, essentially, I had no idea there was loads of these different types of receptors for these different endogenous systems. And I read this complex paper on the opioid endogenous systems, and there are different types of receptors and different opioids, because beta endorphin is just one example, that have higher affinity to different types of receptors. So yeah, that was my way of, as you would say, Carl, spicing up the paper, making it sound.
So you can supplement your pain relieving BFR exercise with some brisket.
Yeah, brisket.
What I understand. Okay, all right. So we've got that.
That's my interpretation.
In Austin, Texas, we know brisket kills coronavirus. We've established that, and now we know it's going to help your pain.
Yeah, I mean, Luke, I'd be really interested to see, and obviously I'm sure you guys are probably going to go down this road of the passive BFR with those papers, the pre-surgical papers, because based on their protocol, it seems like, they should be under Versed already. I mean, it's like right before surgery. So there probably isn't as much of a conditioned pain modulation fitting in there, because they probably aren't really feeling it. Maybe more of that pressure change or the baroreceptor type mechanism fitting in there. But I'm be curious to see how that compares to, an exercise application with the tourniquet.
Yeah. So the condition pain modulation, I find that really interesting. And exercise acting as a noxious stimulus to reduce the pain itself of the injury. And we included, so we had measures of discomfort, which obviously isn't the most robust measure for that. We had our measures of discomfort and that mediation analysis I mentioned, where we did beta endorphin and the change in sensitivity. We also looked at a relationship between discomfort and changing discomfort and changing thresholds based on that. And it suggested, again, it was an influence. So essentially there is that, particularly if a higher percentage of LLP is causing greater hyperalgesia. But again, it's probably just one in several. So the hope is that in some way we can, not for the aerobic stuff that we have already going, but if we can get me trained on the TMS stuff, we can then maybe dig deeper into what's happening in those neural pathways. Plus, TMS is cool. You get to shot people in the head with a big hat on. So, who doesn't want to do that?
I don't want to do that.
But you're going to for your first ever visit to the UK, and
yeah, you can shock me with TMS.
You've got less interference.
I got good.
Between
I got
shock
good
and
contact. Yeah. You can get good purchase on my head, no problem.
So, Luke, any future projects you want to highlight?
Yeah, so we're kind of we're going to kind of stay on the pain route for now. So we've got the aerobic one going. We're going to look at doing an IPC type one as well to look at hyperalgesia with that, something like that, kind of passive protocol. The idea is to then start putting it in patients, so getting individuals in. We've already kind of made movements with this, so getting people in and doing an acute BFR protocol with 80% LLP. And then kind of following a similar type design to the Caracas stuff, where get them to do a session after, measuring pain during it, at the end, and then at 24 hours later. And I think the 24 hours is something we're going to push and probably include in all of the studies, because I think, that's massive. We've seen that with different types of BFR exercise. That's great. So there's kind of that avenue. And we're going to dig more into the mechanisms. So that'll involve more studies like the one we've discussed today, the resistance exercise one, that type protocol, but then using the TMS, taking other blood measures, looking at different opioid markers, different endocannabinoid markers, looking at blood pressure and things like that, and trying to dig out and tease out those other mechanisms and really include, pressure. So is pressure having an effect? Because I think that's really important. We're not just interested in if our working, it's like what pressure is optimal for this, because we want to make it optimal if we're going to do it.
I agree.
That's kind of the way we're going with the pain stuff. And then we've trying to set up some more clinical stuff on the side, and myself and Stephen have got a couple PhD students. We have Paul Head, who's doing the BFR and electrical stimulation stuff. A couple of new potential students looking at lower back pain and BFR. So we've just had a master's degree student doing nice on BFR and lower back pain. So that's really interesting. So the idea is to see if we can kind of follow that up, and the systemic hyperalgesia is kind of, I'm really interested in that, not to give like ideas away, but I'm really interested in like an upper versus lower body. So, by training an upper limb, do we get a reduction in pain in the lower limb? We've essentially shown that in the first study. But then also, so now go, okay, well, in someone who actually has pain in the knee or the foot or whatever, if we train an arm, do they get a reduction in pain in that? And what are the mechanisms with that? So I think that's kind of, I think the important thing now is I'm just trying to understand how it worked. And that's kind of the way the BFR literature went initially with strength and hypertrophy. Oh, well, the muscle's getting bigger and it's getting stronger. And then after a while, people are like, okay, how's this working? So I think that's kind of where we're at now.
Nice, man. And you're also looking at outer space.
Yes, that's kind of, that's my main kind of topic. I'm a space nerd, have been since I was a kid. So my dream of being an astronaut still might be slightly alive, but minus being a pilot and an engineer and all that. So,
but I'll see if I can get a hold of Elon Musk for you. He might be able to hook you up.
Yeah. I ain't getting on your rocket ship, Luke. Sorry, man.
The goal is to have a BFR device floating in space. That's the goal.
Yeah.
Well, man, Luke, you're crushing it, brother. You're changing the clinical practice and putting out some amazing work. So it's fun watching all this happen and trying to keep up with you now. You're speaking at more conferences than I do, which is fine. You can have all mine.
Yeah, thanks, guys.
Yeah, and you've got you're teaching some BFR courses with the Ability Group in Italy coming up. I think those are all sold out.
Yeah, they're completely sold out for two in November.
And then you have some courses in London as well.
Yeah, we have some courses in London. Next one in August, and then we're in November. So just really hoping that those things pick up back now. I think one of the previous ones was 24, so it's good. The more people, the better on those things. So
yeah. The world's slowly getting back out. Well, fellas, you got anything last parting words or ragging on Luke for anything? I know you guys always got your jokes.
Good. Gotta save some of those for another time. Yeah.
All right.
Look forward to getting to hang out again soon.
Luke, that's awesome, man. Thanks for coming on. Great stuff. A lot of people are getting a lot of information from this. So appreciate you, brother.
Thanks, you, Luke.
Guys, that was fun.
All right. Say hi to London and the Drury Weather and Stephen Patterson for us.
I will do.
Hey, I got a question, Luke. Wait, before we leave, did Stephen ever drink the Welsh whiskey? You got him?
No, he didn't.
Did he ever hear?
No, I don't. No, and I hope he's listening. He's going to listen to this. I'm going to send it to him. That was my other supervisors post PhD were like, "Oh, this is a really nice gift." And like, I'm not drinking that. What's that? Just like, because then we came to Washington, didn't we? The day after my so I'm already feeling a little bit delicate that day after being in the pub. So that flight, and then go meet you guys, and we go out for a drink, and it's the first thing he brings up, and 2 minutes in, and I'm getting laid in. I was like, I'm going back to the hotel.
Stephen can only hang with beer. He can't handle the hard stuff anyway. So, he's our new weak sauce.
I remember leaving there, and he when he moved back to Belfast, he definitely can't handle alcohol. So
yeah,
that's too funny. Too funny.
Got the weak gene. All right, fellas. Thanks again, Luke.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.